The pulmonary arteries and the pulmonary veins are the cause of the so-called pulmonary vascular markings. Do not refer to bronchovascular markings because the bronchi are not seen unless we see them on end and unless the walls of the bronchi are thickened. So for all practical purposes, the vascular markings of the lung are formed by the pulmonary arteries and pulmonary veins. The bronchial arteries and the bronchial veins and the lymphatics are so small that normally they do not cast the radiographic shadow. In this subtraction angiogram, we see exclusively the pulmonary arterial branches. The left hilus is slightly higher than the right, and the markings to the right upper lobe are smaller and fewer than those of the lower lobes. In this pulmonary angiogram, we labeled some of the vessels. The purpose is to show you that the left pulmonary artery, which is a continuation of the pulmonary trunk, is slightly higher than the right because, as you remember, it runs from front to back above the left main bronchus to branch behind the left main bronchus. Whenever we see elevation of the right pulmonary artery at the level or above the projection of the left pulmonary artery, in the absence of lung disease, we have to suspect some congenital anomalies, occasionally some types of transposition of the great arteries, or the so-called double outlet right ventricle will produce a bifurcation of the right pulmonary artery at the same level or above the bifurcation. In this angiogram, we can see the pulmonary arteries in black and the pulmonary veins in white. The totality of the lung becomes opacified, that is, the markings of the lung are filled by contrast, which is in either the pulmonary arteries or in the pulmonary veins. The two places where we can separate arteries from veins are in the right upper lobe as well as in the right lower lobe. Note that in the right upper lobe, the black artery is medial to the right upper lobe pulmonary veins, and in the right lower lobe, the right lower pulmonary artery parallels the right heart border, and the pulmonary veins of the right lower lobe run more or less horizontally or obliquely, crossing the right lower pulmonary artery in an X fashion. The horizontal vessel that we see between the heart and the right lower pulmonary artery are right lower pulmonary veins. This is the venous face of a pulmonary angiogram where the pulmonary veins appear in white. Note that the confluence of upper lobe pulmonary veins on the right side contributes to the right hilar shadow. In other words, the shadow of the right hilus is formed by the bifurcation of the right pulmonary artery and the crossing of the right upper lobe pulmonary veins in front of the pulmonary artery towards the left atrium. Whenever there is a distension of the right upper lobe pulmonary veins, instead of the right hilus being concave or straight laterally, it becomes convex laterally because of an increase in size of the right upper lobe pulmonary veins. Also note that the pulmonary veins of the right lower lobe, as well as those of the left lower lobe, run a more horizontal course because the venous hilus is caudal to the arterial hilus. The venous hilus, which is the confluence of the right and left pulmonary veins, anatomically projects below the right pulmonary artery and below the left main bronchus and the left pulmonary artery. So the venous hilus is different than the anatomical hilus of the lung, which only has the bifurcation of the pulmonary arteries and the upper lobe pulmonary. The pulmonary blood volume depends on the number of vessels, the distensibility characteristics of the pulmonary vascular tree, the total blood volume, systemic and pulmonary vasomotor activity, the balance between inflow and outflow tracts as determined by the respective actions of the two ventricles and by ventilation. This is a diagram which shows the higher position of the left pulmonary artery as compared to the right. So the anatomical right hilus should always be caudal to the left. Dr. Felson has published that occasionally the bifurcation of the right pulmonary artery is about at the same level, but this is a rarely seen. In this case, there is cephalic displacement of the right pulmonary artery by a massively enlarged left atrium. Note that the rounded density that we see below the right pulmonary artery, which curves around this density, is a massively enlarged left atrium. This patient had congenital mitral insufficiency. My friend Maurice Simon from Beth Israel Hospital has published beautiful diagrams to contrast the position of the pulmonary arteries and pulmonary veins in the upper and the lower zones of the lung. Normally, the arteries and veins of the lower zones are larger than those of the upper zone because by gravity in the upright position, blood tends to flow towards the lung bases, and also because anatomically the lower lungs are larger in volume than the upper lungs. Here you can see in blue the pulmonary arteries and in red the pulmonary veins. Note again that the right upper lobe pulmonary vein is lateral to the right upper lobe pulmonary artery. On standard frontal radiographs of the chest in the upright position, we can see that the vascularity of the upper zones is markedly reduced compared to the prominent markings of the lower zones. Again, this is a reflection of more ventilation and less perfusion. It's a ventilatory perfusion inhomogeneity, which results in air going easier to the upper lobes, blood going easier to the lower zones. The markings of the lower zones are also larger because of the larger size of the lower lobe. My friend Dr. John West has emphasized the pulmonary dynamic anatomy, where ventilation and blood flow homogeneity is quite apparent. He has described the three zones of the lung that show the alveolar capillary pressure relationship. In the upper zones, the pulmonary alveolar pressure exceeds the pulmonary arterial and pulmonary venous pressure. In the lower zones, the vascular pressure, that is the pressure in the pulmonary arteries and pulmonary vein, may exceed the pulmonary alveolar pressure. Therefore, the markings are prominent in the lower zones and are inconspicuous in the upper zones. In the mid-zone, the pulmonary arterial pressure exceeds the alveolar pressure, and the latter, the pulmonary venous pressure. In an upright view of the chest, again we note the markings to be prominent in the lower zones. If vessels would extend all the way to the edge of the upper lobes, one has to assume some increase in the pulmonary blood flow and volume, as seen with left to right shunts. We can also see that in patients who have the so-called athletic chest, where pulmonary blood volume is increased. We also see it in patients who have a redistribution of blood to the upper lobes because of bibasilar pulmonary occlusive disease, like bibasilar pulmonary embolism, or bibasalarly predominating emphysematous changes. So the flow redistribution has different connotations. And in patients who have arterial and venous vasoconstriction in the lower zones, as seen in mitral stenosis and left heart failure, there will be a flow redistribution to the upper lobes, and the vessels may appear to reach the edge of the lung. In normal situations, usually we do not see markings at the very periphery of the upper lobes. When doing CTs, because the patient lies supine, we may see more prominence of the vessels in the lower or dependent portions of the lung. So the positioning of the patient may also influence the appearance and size of the pulmonary vessel. In this patient with pulmonary congestion, we see engorgement of the dependent vessels, which are in the dorsal aspect of both lungs. Note bronchial wall thickening, which is a result of increase in the connective tissue of the peribronchial and periarterial zones, the so-called axial connective tissue, which is another expression of interstitial pulmonary edema. The ground glass appearance was the result of interstitial pulmonary. The best anatomical detail about the pulmonary vascular tree is obtained by selective pulmonary angiography. Here, the left pulmonary artery was selectively injected, and one can see with exquisite detail up to vessels that are 0.5 to 0.3 millimeters in diameter. This is a case that I got many years ago from my friend Gordon Gamsu from California, of a young man who was asymptomatic, and we can see on the plain radiograph that the vascular markings are somewhat irregular and that there are areas that have hypoperfusion. We are now going to show you two composite slides that have a selective and super-selective injection of the right and left pulmonary arteries. Note that there is tortuosity, areas of oligemia, and we see some cutoff of vessels. So the question was, could this be a case of silent recurrent pulmonary emboli in an asymptomatic individual, or could this be the result of an arteritis that has occluded many arterial branches? And because of the chronicity, we see the tortuosity of the intrapulmonary arteries. We do not have a histologic confirmation. The last four images are of the left lung, and the bottom right represent a selective bronchial arteriogram of the right upper lobe and shows increase in the size of the bronchial artery. So retrospectively, we can assume that this young man had an arteritis or pulmonary emboli that occluded branches of the pulmonary artery, and that there was a chance for the bronchial arteries to compensate, and that's why they appeared enlarged. So irregularities of the pulmonary vascular markings may be the result of a small vessel or even medium-sized vessel obstructive disease. And the bronchial arteries can contribute to the blood supply of the lung as long as ventilation is maintained and we have some backup of systemic arteries, parenchymal changes may not be observed. Dilated bronchi filled with mucus, so-called mucoid impaction, can mimic enlarged pulmonary arteries or veins. This is an example of mucoid impaction where dilated bronchi filled with mucus simulated enlarged pulmonary arteries or veins. But note that they are perihilar, they do not extend all the way out to the lung, and usually the patient has a history of asthma, aspergillosis, etc.